Good afternoon, everybody. I am Dr. Lee from Samsung Medical Center, and our co-operator, Dr. John, will help this renal AVM procedure.
Good afternoon. This is our case. Our patient is a 64 years old female. She referred to our hospital. The ultrasound showed some abnormal findings in her right kidneys. This is the CT scan. You can see tortuous and dilated vascular structures in her right kidney between the upper pole and the renal hala areas. And you can see the early contrast pooling in her right renal veins. This is the coronal images with the MIP reconstructed images. You can see tortuous and dilated vascular structures with the early draining veins. In this case, we think this is some kind of more complex AVM, such as 2A. So this is the end of my briefing.
As is shown on this angiogram, you can see some multiple feeding artery arising from the multiple segmental branch of the right renal artery, and make one big early enhancing nidus, and then one single draining vein going toward to the IVC. So today our first strategy is transvenous access to the venous sac, and then we are trying to coil embolization of the type 2A AVM. If the transvenous access failed, second option is direct stick and coil embolization. Do you have any recommendation on this case? Which access technique is the best for this patient? And do you have any suggestion to treat this case? I'm approaching the transvenous access from the right femoral vein. We will use a 5-branch long sheath answer, and also we second catheter is 4-branch Berenstein catheter. As you can see on this angiogram, we successfully engaged into the single draining vein. After that, we need to find the very small hole from the AVM nidus. So it will be challenging procedures. At first, we are trying to use a microcatheter to negotiate the small hole to the AVM nidus. As you can see, it was fortunately very happy condition. We tried just once, and we got into the AVM nidus. Please measure the size of the loop of the micro wire, and then we are doing transcatheter venography, and then evaluate the anatomy of the venous sac. But as you can see, 4-branch catheter does not follow the micro catheter, so the size of the hole is very small. So we cannot use 0.35-inch coil. So we are trying to use Congenital 3D coil first to make the stable flame of the coil mass, and then we add additional coils to embolize the tight packing of the type 2A AVM. So the measured length of the nidus is 19.5 millimeter. So we can use biggest 3D concert coil. As you can see, the transcatheter venogram, uh, we, we found exact location of the coil embolization. Compared to the arteriography, there will be numerous feeding artery joining into that venous sac. We called it as just a nidus of the type 2A AVM. We will embolize the sac with a coil first. This is the 3D coil, 12 millimeter in diameter, and the length is 40 cm. Okay, detach. This is the first coil. We are going to use additional one more 3D coil. This is the second 3D concert coil. Depending on the anatomy of the nidus, some part cannot be occluded by the just coil. At the time, we consider liquid embolic material like ethanol or glue or onyx. But in Korea, we cannot use onyx for AVM embolization. Sometimes it is very difficult to identify the tip of the microcatheter in the coil mass. So sometimes it is very tricky to using the detachable coil or other system, and also rotating the X-ray tube can make us more information about which part of the coil mass is radiolucent, which part is dense. So we need more coil, 10 millimeter 3D. Shunt flow is markedly reduced, and we will check for the transarterial angiogram. We used 7 detachable coils. During the procedure, we checked arterial angio, and the flow was slowed down, and this angiogram shows almost AVM disappeared. As you can see, delayed page, there is an unthrombosed feeding artery around the AVM nidus, but I believe it will be thrombosed spontaneously after the embolization. Do we need additional coil or just stop the procedure? Do you have any recommendation? I think we can use 2 or 3 more coil to make a more tight packing. In our institute, we published 2 clinical studies of the renal AVM. First one is how to treat the renal AVM. The answer was according to the AVM angiographic classification. We are doing the transvenous coil embolization type 2A AVM, and also in that paper another type of the AVM, we can use a different treatment strategy. I will check the venous catheter angiography to determine the status of the AVM after this coiling. This is a very beautiful image of the AVM after embolization of the nidus of the dilated vein, and then through the transvenous microcatheter, angiography shows multiple feeding artery joining to the AVM nidus, and it reflux to the normal parenchyma. So, do you think additional ethanol embolization is needed?
Yes, I think some ethanol.
Yes, yes. Okay, okay. We will make 80% ethanol to reflux the adjacent area of the feeding artery. That kind of strategy is the most reliable tools to treat the type 2A AVM like this. However, we should keep in mind that ethanol should not be refluxed to the renal parenchyma. So we need a repetitive angiogram to determine the speed of the ethanol and total amount of the ethanol injection to prevent normal parenchymal injury. Under fluoroscopy, very little amount of the ethanol is sufficient to make embolization of the adjacent feeding artery. So I will use very small amount. So far so good. Do you have any ideas? Do we need additional ethanol or just stop procedure? Do you have any recommendation or suggestion? ACC만 주고 이건 조영제인가요? As you can see, small amount of the ethanol refluxed from the AVM nidus to the feeding artery. I think that is enough amount for this kind of AVM, because almost AVM flow was already stopped by coil embolization. Let's check the final angio again. Thank you for listening this procedure. See you next time. 1 month later, the patient returned to our clinic, and the follow-up CT scan shows a complete resolution of the AVM. The previously visible early draining vein is no longer seen. So that's our result. Thanks again for listening, and see you next time. Bye bye.